everyone. That was very embarrassing. Thanks, Liz. So what I'm going to try and do is make this really interactive and have a good flow of conversation between our panelists. So I'm going to try and talk as little as possible and let our expert panel be the ones that steal the show. So with that, I'm going to invite all of our panelists to come up, and I will let you speak for yourself and introduce who you are to the group. Yes.
You want to come up? How do you want to do this?
Anywhere.
There's a microphone. Oh, yeah. Do you want to hear?
So we'll start from this way. I know all of you have heard Shannon speak today, but if they're...
Me again.
Alan, do you want to take some time and tell the group who you are?
Sure.
Mm-hmm.
So my name is Alan Burch, and I'm a drug access facilitator here in Toronto. And my job is to assist patients with accessing their medications, essentially. So that works with insurance. I guess that's one of the major sources of paying for medications. We also help with accessing programs through the Ministry of Health. So if you're under 65, you may be getting your drugs paid for through Trillium. So we assist with those types of things, and advocating with patients to drug companies or to their insurance providers to sort of overturn a rejection, things like that. That's kind of our main focus.
Joe?
Hello, everyone. My name's Joe Novak. I'm nervous if you can't tell, but it's good to be amongst great people. I am a Hodgkin's lymphoma stage 3 survivor. I was diagnosed in April of 2016. I got the all clear in October of 2016. I've been in remission ever since. I'm here because Shannon asked me to be here. She was my nurse. She has helped me through my entire journey, including today. So I had symptoms such as the being tired. I had a cough that I thought was from my son being in daycare for what I thought was a few months, but after talking to my mom and getting the diagnosis, I'd had that cough for a year. I started to feel emotional, crying at songs on the radio. I'm an emotional guy, but that's a bit much. Getting tired going up a flight of stairs at work when I play hockey and I surf on the lakes whenever I can. My wife found me crying in the basement one day and said it was time to get checked out. And the rest is history. We're here now. And thank you so much for having me. And one thing I want to add is through my entire journey, 3 years now, I've learned more today than I did before, and it's been a bit overwhelming, but I'm very happy to be here.
I'm Michael Crump. I'm a lymphoma physician just up the street at Princess Margaret Hospital. So I think that's why they invited me, because I could just walk down, I guess. I've been involved in this before. I was the co-chair of the NCIC CTG, that's our clinical trials group, hematology site, and I was the lymphoma working group chair doing clinical trials in lymphoma. I've been the lymphoma site leader at Princess Margaret Hospital for a long time. I'm not doing those jobs anymore, so I have lots of time on Saturdays to come in and hang out with you. So it's great to be here. I'll just say one other thing. So Joe is also on our Ride to Conquer Cancer bike team within the year that he finished treatment. We do this fundraising ride, and it's a bunch of hematologists and blood cancer survivors and their family members. And just to let you know, when Joe crossed the finish line, we all cried. So it wasn't just him. So anyway, it's nice to be here.
Now I'm going to cry.
Excellent. So we know self-advocacy not only helps you more confidently choose your options, but it reduces the anxiety and the fear that comes with lymphoma, leaving you more empowered, giving you agency, which is really important. And studies also tell us that patients who learn more about their disease and are more actively involved in their medical care have a better quality of life. And some studies even go on to say that there may be better outcomes associated with that. So on that, what I would like to ask our panel, and we'll start perhaps with Shannon and Dr. Crump, where can patients get credible information besides Dr. Google, of course?
Ooh.
Lymphoma Canada.
Lymphoma.ca.
No, I mean, I think that your primary source of information should really come from your healthcare team. You know, you can talk to friends, you can talk to family members who also have this type of disease or something similar, and everybody's going to have a different experience or different subtype of disease. As we saw this morning, there's over 60 subtypes of lymphoma, and everybody's going to have their own experience. So I think that you should try not to get your information from Dr. Google and from friends and family, and that it should be with your healthcare team. Do you want to add anything to that?
You know, I agree. I mean, sometimes it's irresistible because, and I don't know how many of you this applies to, but you know that you've learned you might have lymphoma or you probably have lymphoma and you're waiting for an appointment, and it's tempting to wander off into websites and look up and then realize there's all these lymphomas, and you come and say, do I have Hodgkin lymphoma? I thought I had this, and you've researched the wrong thing. So sometimes it's better to wait until you've at least had an encounter or two to clarify what the diagnosis is, and actually probably will allow you to maybe focus what your questions are as well, because lymphoma is a broad thing, and there's all kinds of treatments, and stage matters, as we talked about. So sometimes having those interactions, like we care very much about that you know about your condition and the side effects of the treatments. Are like that's what we do. We feel passionately about that too. But it at least allows you to focus on what the relevant questions are as a starting point anyway. I would say there are some really, so in terms of credible sources of things, there's so Lymphoma Canada has one, the Lymphoma Research Society in the US is another place that has good patient information. If you go to, there's a UK website, Cancer Research UK, also has patient information sources. I think the reason why we like those is because we kind of know the people. The US NCI has a lymphoma. If you go to, I think it's nci.gov, they have a website that also has, and we're comfortable because at least the data that's out there has been vetted in some way. It probably reflects current research and understanding a little bit more. Not to say that everybody has to conform to what the doctors think, but at least we can understand what is being said, and that we could refute or not the references they've quoted for those resources. So I think finding credible resources like that as a starting point is a good idea. There's tons of stuff out there for you to look at, but I would recommend those sites as places to go, at least as a starting point for those conversations.
And also, just to add to that too, I quite enjoy being like a myth buster at work, and so it's quite fine to do your own reading and come into the hospital with these questions because you know, we're here to sort of clarify, no, actually that's not true, or this is actually more appropriate for your disease type and that kind of thing. So we do appreciate that you do some reading, but bring your questions forward because a lot of your assumptions may in fact actually not be true.
That's great. So Dr. Crump, you brought up the importance of knowing your subtype. Shannon, do you want to expand on that a little more?
In what way?
Why is it important for a patient to know what their subtype is? How does that actually help them feel more empowered?
Right. Well, I think knowledge is power. I mean, every different subtype of lymphoma is treated quite differently, and Dr. Crump can talk more about that. But, you know, understanding the basics of do you have non-Hodgkin's lymphoma versus Hodgkin's lymphoma? Do you have an aggressive form of lymphoma versus an indolent? And all of these are sort of treated in a very different manner. And understanding that sort of, you know, natural history of disease can help you frame your expectations around what to expect during the treatment journey.
Great. So, Joe, I'm going to take it to you. And what I'd like to know from you is where did you find information? I also do want to know what did you do to feel more confident about the decisions that were in your healthcare, with the decisions that were made. How did you feel confident about them?
I might need you to follow up with the second one. That's part of my, the brain fog is still around 3 years later. So as soon as we found out, friends and family basically assembled the team that helped me beat it. And I think we all beat it together. With regards to Dr. Google, all internet research was immediately outsourced to a good friend my wife would ask a question or I would ask a question, and she would go and do the research and came back with what she thought was important and weeded out all the, for lack of a better term, the scary stuff. So I had a team that stepped up quickly to just allow me to just fight. All I had to do was fight. I didn't have to think about anything. If I had questions, it would come back in a constructive way and not one that would drag me down. And then what was the second part?
You sort of touched upon it, but what did you do to help feel confident in the decisions about your diagnosis and treatment?
Okay, so I feel very fortunate because I have an amazing relationship with my family doctor who handed me off to Shannon and Dr. Prika, Princess Margaret. So that his backing of Princess Margaret gave me a lot of confidence right from the start. And then the demeanor of Shannon and Dr. Prika as my team made me feel confident. There was never a mention of, you're not going to beat this. There was always a talk of, you're going to beat this. One beautiful story is I was halfway through my treatments. I was waiting to do blood. Shannon walks by and says, hey, when you beat this, you're going to do the Ride to Conquer with us. So that gave me a lot of hope and say, hey, I am going to beat this. There is a light at the end of this tunnel, and I can't wait to do one of the hardest things in my life. So it was little things like that, the confidence in my team, everyone at the hospital down to the blood workers, everyone just knowing when to laugh with me, knowing when to be quiet, knowing just how to read the room basically and treat everyone differently. And I saw that and we've all the patients have seen that when you're in the chair for treatment, certain nurses treat patients different ways. And that gave me all the confidence in the world, and yeah, I'm here.
Great. So we all know communication is important in any relationship. It could be a relationship with your spouse, it could be a relationship with a family, but also it can be a relationship with your clinician, with your physician. A relationship with your doctor that is based on communication can inform, can empower the patient, but also have trust, build that trust not just between the patient, but between the patient and your physician. So with that, what I would like to ask Dr. Crump and Shannon, based on your experience, what can patients do to improve communication with their healthcare provider? Should they come with, say, a list of questions that they have? Should they bring someone with them that is a trusted family member? Should they ask for access to things like their reports? What should patients do when they come see you?
I'll start. I would say I'm going to openly admit that our healthcare system is terrible at communicating with each other. In terms of other outside hospitals, communicating in particular with large cancer centers. We don't have very good communication tools and very good sort of electronic tools to communicate with each other. And so that, I can see it being very distressing in patients when they come into the clinic and they, and I ask them, what has happened, or tell me your story, and they have to tell their story over and over again, and I can see that, and I appreciate that that's a humongous challenge. But what is really helpful, and I love it, is when patients come in and they have a documented piece of paper that has all of their medication history on it, all of their past medical history, and even sometimes some point form notes about what's gone on over the last few weeks to a month. It makes the clinic visit more efficient, a little bit more organized, and helps you not to forget things that may have happened.
Yeah, I agree with what Shannon said too. Please bring your medications with you. But I also agree with what you said, which is I think preparing ahead of time is a good idea. I'm probably going to look at somebody in the audience who once sent me a list of she was at least polite enough to send me an email saying, these are the 20 questions I want you to answer when I'm coming to the clinic. And I said, okay, you have to pick your top 5 because, we can either set aside 2 hours to answer your 20 questions or what are the things that are most important to you? So I agree, I use that as an example because I think when that appointment happened, actually, the most important things, I hope you think that was funny what I just said. I think we addressed the most important things. And it's, at the same time, I think it was good for us to, or for me to reflect on, I've been looking after this woman for a long time. Why does she have 20 questions about what's going on? What did I forget to say in all of our other encounters? So anyway, I didn't think that was a bad thing because I reflected on my communication with her in the past and maybe I'd missed something. So I think you want to be able to make sure that you're hitting the highlights when you come, the things that seem to be that are the most important. What are the things you want to really get the answer to, and what are the things you think you could reasonably defer? And I appreciate sometimes even that sort of filtering may be difficult, especially when you're at the beginning of the journey, but if you can focus on the highlights. I do think actually having somebody come with you, it's really, really important. You know, I think Joe described sort of the outsourcing of the internet tasks, because some people just find the information, the internet is a terrifying place to go, and I don't want to, I'm already scared. I want somebody else to make the whole thing less scary for me. So at the same time, having somebody there with you in those moments where, you know, somebody has said something about your pathology report that all of a sudden things are less favorable, you stop. Shannon and I both have had this experience. Like, we know at the time in the interview when you've stopped listening. I can tell by the look on your face, and you know, and then the rest of the things that I was going to say are they're not going to be absorbed. But if you have a scribe there or somebody who is just, you know, that can take that role on, I think it's really, really helpful. I appreciate. For the caregivers in the room, that's a huge burden. Everybody has to take time off of work, and you know it's really tough to do that. But you know yourself, or you know your loved one, and when it's time to be there with them to make sure that the messages are received and remembered, because like I said, we can all tell when the processing is stopped, and you're going to go home wondering why didn't Dr. Crump answer this question, but partly we realize the circumstances such that you don't necessarily retain what was said. You mentioned one other thing. I forget what the third thing was. Bring somebody, write things down.
Online reports or reports in general.
Yeah, so the last part, I guess, so I agree with what Shannon said at the beginning, that there's the disconnect between institutions. It's getting better. There are more electronic communication links between one hospital and another. But now you're actually more able to get access to your pathology report, and we talked about this in our session, or your PET scan report. Those are the two things I highlighted. And I think I think you have to make that decision for yourself. The warning that I gave to the group this morning was those reports are being written for the clinicians who are treating you. At UHN, there's a disclaimer on the bottom of the radiology reports that basically says, I didn't write this for you, I wrote it for your doctor, so if it upsets you, not my fault. And the pathologists are kind of like that too. So it's all inside baseball, it's all written in terminology, and that's regrettable. But I know that these professional bodies have decided they don't want to compromise. They don't want to write a lay person's description. They don't want to do that, and don't be mad at them. But also don't be afraid of what you're reading. I think you have to decide for yourself: you're going to be okay with what you're reading on that report? You know, can it wait a few days until you come and see me, or do you think you're going to have to phone right away because the whole thing is frightening you? Maybe going down to the patient portal isn't the thing for you then. So we're always happy to talk, you know, at the clinic in detail about whatever you've read that freaks you out. But it's a daunting world going on and reading those reports. It's okay to look up your CBC and figuring out what your hemoglobin is. That seems a little bit less intimidating. But it can be a bit of a worrisome thing reading a pathology report and wondering just exactly what all of this meant. So it's good to be able to know these things ahead of time, but I think you have to know yourself as to whether or not that's really going to reduce your anxiety, or is it just going to make things worse?
Joe, what one piece of advice can you give to a patient who would like to have a better communication with their, or perhaps even a new patient coming in to see their doctor for the first time?
I would definitely say having an advocate helped. Like, my wife was my rock, as our partners and family members are for all of us. But to be able to have that person be able to ask the questions, and back to the last question, we have a binder, which we still have to this day, and I crack it open every now and then I have to close it because I don't always like to go back there. But we would write the questions, and when we'd have our appointment in a week or two, then we'd bring the binder in and go through all the questions. But don't go into it alone. That would probably be my biggest advice. Don't be afraid to ask the questions. And if you trust your healthcare professionals, trust them. They know what they're doing, they're trained in this, and that can give you just a little bit more hope and confidence and to get you through it.
So one of the questions we get at Lymphoma Canada very often is, can I get a second opinion? Should I get a second opinion? How do I get a second opinion? Would my doctor feel offended if I were to want to get a second opinion? Shannon, Dr. Crump, do you have anything you'd like to say in terms of how to address these with patients?
I'll let you go first, because I can tell you what patients tell me. They may say something different to Dr. Crump, so I'll let you go first. And then.
So most of the time, most of the opinions, the requests for second opinions that we get are coming probably via you through your family doctor. Not very many of them actually come from, so we need a referral, and most of the time that source is your family physician. And I'll just say that nobody has a monopoly on the right answer in the treatment of lymphoma, like lots of other cancers. If we wouldn't be having this forum if it were 100% successful. You wouldn't have anything to worry about. So I don't think anybody actually, as a professional, I don't object when people go off and see somebody else. And I don't think you should worry that you're going to alienate your oncologist or the healthcare team that you've carefully put together, as Joe described. That's not going to happen. These are also professionals and who know what I just said is true, that there's no monopoly on the right answer or cure in this disease yet. So a lot of the referrals, that being said, come from family physicians. And I would just say on the receiving end, we're happy to see anybody. I think framing the question about what was it about the first opinion that prompted the second one? What is it that you want to know? And sometimes it's just saying, like, is this really what everybody would do? And that's a lot of it. Like, what would another person reasonably do? But sometimes there's another question you want to ask. And if that's the case, then ask it. Like, be explicit about why you're coming. It just makes it easier for us to figure out, how urgent this is, and also to be prepared to be able to answer those questions. So family doctors are often charged with this task. They may not have as to Shannon's point earlier, they may not have all of the information about you. Unfortunately, every piece of paper doesn't flow from my hospital to your family doctor's office. I don't know if they can get radiology reports or not, other than whatever software they have on their electronic patient record. And bring a CD with your imaging on it so we can have a look at it. But I think there's always a reason to, or I'm not saying I feel like in America it's like you have to have 2 or 3 opinions in order to get started. I'm not sure we're quite there, but certainly it's a reasonable thing to ask. I would say that one of the main reasons why we see people is either to think about a clinical trial, and maybe Sabina was going to talk about that later. But the other is about pathology. Like, actually, I feel like a lot of people who are coming to see me are actually coming to see my pathologist because they want to know whether or not the diagnosis from wherever they were is actually correct. And that's totally legit, because we know that expert pathologists will disagree with each other from time to time, and there's research that shows somewhere around 10 or 15% of diagnoses change when you send one pathology specimen from one hospital to an expert referral center. Now, sometimes those changes are not hugely important. They don't change treatment fundamentally, but sometimes they do. So anyway, I'm humble enough to realize that a lot of people are coming to see me, or actually coming to have their pathology reviewed and have that signed off, and that's great. I think that's important. It's a really difficult discipline. Hematopathology and lymphoma pathology is tough, and sometimes that requires 2 eyes as well. So.
Shannon, do you have anything to add?
No.
Can I just say, and maybe Shannon's just being polite. I will say that one of the reasons why people come to see me, I'll just say, I don't know, and my colleagues as well, is because we feel like the communication hasn't been very good. Like, we'll go through the second opinion, have discussion, and they'll go, wow, you just had a whole bunch of things that my other doctor didn't say. I've learned so much more about my lymphoma, now that I've come here. And so actually, I feel good about that, not because I felt like I've done a better job than your doctor. I just feel like it's actually reinforcement. Remember what I said about at a certain point in the conversation, you stop listening, whatever was said isn't going in because you're so frightened about what the conversation's about. So I don't really believe, because I trained most of the people who are your doctors, that they don't, that they're not saying this. And maybe they don't, maybe they aren't, but I know that sometimes it's just, being in a different environment and it's a bit more relaxed and it's not the first or second time you've had a cancer diagnosis, and it's just easier for everybody to kind of take everything in. And so I find some of the most satisfying things are when people said, oh yeah, he didn't say, or he or she didn't say that. And I can tell from reading the notes, yeah, they did say that, but I'm just here to reinforce that you're, on the right path, you're in good hands. And so those are fine too. I think the communication in cancer treatment is really challenging because of, there's so much emotional investment on everybody's part. And so sometimes we're just there to make sure that the communication is clear and the messages are clear, and everybody, it's teamwork to look after people with lymphoma.
And it's a good it's a good way of self-advocating. We have to be comfortable or knowledgeable about the decisions that you're making for your own body, and so I think that's it's reasonable and accepted and expected in some cases to sort of seek other opinions. So I think it's a good thing.
Okay, we're going to switch gears a little and talk a little more about understanding cancer drug funding. So most of us, we're fortunate to live in a country with a universal healthcare system. What some people don't realize is that not all drugs or healthcare services are paid for by our provincial government. And we only find this out usually when we actually need a therapy that is not available or accessible to us. And so in Lymphoma Canada, we actually get a lot of questions from patients who want to know why a treatment that their doctor has recommended is not paid for the government. And in addition to all of this, there's also several public and private drug plans, programs that exist, so it's definitely very intricate. So let's spend some time to talk a little more about accessing drugs. What I'll start with, perhaps, Dr. Kramp, is if you could give us a very brief understanding of of how a drug is approved by Health Canada, but really more focusing on if a drug is approved in lymphoma, it's very specific for a specific type and aligned. So perhaps if you could just talk a little about that.
Yeah, so usually I have like about a dozen slides to address this point. So I can get my computer if you want. So there's a few layers. There's Health Canada, and there's this thing now called the Pan-Canadian Oncology Drug Review, which makes evidence-based decisions. And then there's the provincial cancer agencies who still get to make a call. So Health Canada says the data about this agent are decent and the manufacturing's fine. So they spend, it's safe for Canadians to get this, and it's probably reasonable treatment as well. But they don't adjudicate evidence or the quality of clinical trials necessarily. They just say it's manufacturing's okay, drug seems to be active, over to the next layer to decide how you're going to use this. They don't make a decision. They make some decisions based on use. PCODER, which is this group that actually is saying, so in our socialized healthcare system, is this a good use of your tax dollars to treat people in Canada with this agent? How good is the quality of the evidence, and how cost effective is it? So balancing all of those things, activity of the drug, survival, patient quality of life, and economics, that's what goes into the decision about whether or not a drug would move forward to be approved by a provincial provincial cancer agency. Right now in Ontario, we have a provincial cancer agency called CCO, and most provinces do. Ultimately, because the provinces actually pay for 85% of your health care, they can decide whether or not they're going to fund a drug. So Health Canada can say yes to a particular agent, and PCODER can say it's probably cost effective, or it's kind of expensive but worth it. And then the province would say the budget impact is too high, we can't afford this without raising our taxes, and then we won't get elected, so we're not going to do it. That's really, sadly, that's kind of what it is. So to go back to the beginning of it, a drug may be approved for use in lymphoma, but it's going to be approved in a particular circumstance. So, obinutuzumab is now approved to be used in follicular lymphoma in rituximab refractory follicular lymphoma. But the data for other circumstances, like using it in diffuse large cell lymphoma, using it in follicular lymphoma frontline, weren't as persuasive. Effect size was not very big, toxicity was kind of significant, and it was not judged to be cost effective or improve quality adjusted life years of life for patients. So it wasn't approved to be funded. And basically that means that there's a silo now. You can get obinutuzumab for refractory follicular lymphoma, but it's not going to, even though it's approved by Health Canada for follicular lymphoma in general, it's going to be used in a specific way by the provinces in a way that's been judged to be cost effective. So it's a bit frustrating because you think, like, why couldn't it just be used for everything? But I think there's kind of, it feels like siloing, but really it reflects the quality of the evidence that was used to make the decisions. The dilemma here is that not all the trials that are used, that are available for a drug, are randomized phase 3 trials comparing old standard to a new standard. Sometimes it's just, we treated 100 patients with Hodgkin lymphoma with brentuximab. And so that's great that brentuximab was approved that way, but people who are over the age of 60 who haven't had a stem cell transplant can never get brentuximab unless they're going to pay for it. Because a clinical trial enrolled a particular population, Health Canada approved it in that population, PCODER did, the provinces did. So I can no longer get access to brentuximab if I have relapsed Hodgkin lymphoma unless I have a transplant because I was too old to be in those trials. So there's blessings and real difficulties with how drugs get approved, but they're really actually approved for fairly specific indications. If you live in America and you want to give lenalidomide to a patient with brain cancer, you can do that. You can't do that here because there's no data about giving lenalidomide to patients with brain cancer. So we have the advantage of having a lot of really good treatments available to us, but it's a little bit, negotiating those niches about where it's being used is challenging for your healthcare team, and it's probably, and maybe financially challenging for you. I hope that made sense. But.
Let's talk about provincial access. So Alan, could you expand on that and tell us about how cancer drugs are funded in Ontario?
Sure. Okay. This is complicated. So each province has funding jurisdiction except for a few federal programs like Veteran Affairs, but most of it, like you said, is through the provinces. When it comes to cancer drugs, there's 2 funding pots in Ontario. So if you're getting an IV drug, it's going to go through Cancer Care Ontario. So the hospital will pay for the drug and CCO will reimburse the hospital for your drug. So that's anything IV. If you're getting an oral therapy, like ibrutinib or something like that, or venetoclax, that's going to go through the Ontario Drug Benefit. So that's for all other drugs. So it's injections, tablets, capsules, anything like that will go through the Ontario Drug Benefit. If you're over 65 in Ontario, you're automatically enrolled and you get seniors coverage, so that's the Ontario Drug Benefit, or ODB. If you're under 25, you also get that because you're part of OHIP Plus. But everyone in between, it's a lot slower, unfortunately, so you have to apply to get that same coverage. So you have to apply to a program called the Trillium Drug Program, and that'll get you the same coverage as someone who's over 65, but you have a deductible with it. So if you're over 65, you may have a $100 deductible per year every August if you're high income. But if you're under 65 but over 25 and you've applied to Trillium, you get a deductible based on your household income. So if you have a very high income, you have a higher and higher deductible. And that can be cost prohibitive depending on which treatment you've been prescribed. But in the world of oncology, we are fortunate because we have patient support programs and a lot of them provide financial assistance to patients. So I don't think anyone really of my patients are paying their Trillium deductible. By and large, most of the people, not all of them, but the vast majority get their deductibles paid for through a patient support program. So it's something that does, like if you're getting ibrutinib, for example, there's a patient support program for that drug, and they'll help provide support for your deductible. If you have a really, really high deductible, they have algorithms, so they may not cover the entire amount, but for the average person, the average family's deductibles may be $2,000 to $3,000 a year, and they will cover that whole amount for you because the drug is like $8,000 a month, so they're making enough money. So that's kind of the pathway that we see for patients who are getting publicly funded drugs. Do you want me to expand on private coverage?
Please, yes,
sure.
that would be excellent.
So if you are fortunate enough to have a private drug plan, you can access these same medications. And also, like we heard, there's some drugs that are not part of the provincial formulary. So the government says you can get this drug for this indication, but it may work in other indications, other types of lymphoma. So when it comes to private and drug plans, sometimes they are more liberal with what they provide. So they'll say, everyone with this particular plan through Great West Life will cover that drug, and we don't look at the indication. So you can kind of get things a little bit off-label in that regard. So if Health Canada's approved the drug, you can sometimes ask your insurance, will you pay for it here and here? And you can kind of get things that are not covered by the province when you have private insurance. The other thing that happens is from Health Canada approval of a drug to provincial listing, it can be a very long time. It can be 2 years, and we're seeing even sometimes more than 2 years for a drug to be added to the provincial formulary. But after Health Canada's approved a drug, a lot of the times private insurance will start to pay for it right away at that point. As long as Health Canada's given the drug a drug number, it's the DIN number, then you can actually typically get it through your private insurance. So sometimes if you have a very robust private insurance plan, you can get a drug well before the province will start to pay for it. So there are sort of benefits by having a private drug plan. You can jump the queue instead of waiting for the province to fund it. You can get things for different indications sometimes, but you are paying for that plan every month through your premiums. The other problem with insurance plans is that they typically don't cover 100% of your drugs. Most plans will cover 80%. So you'll have a copay. And if your drug is $10,000 a month, a 20% copay can be overwhelming and cost prohibitive. Most people don't have 100% coverage through their insurance. Sometimes I even see patients who have 45% coverage with their drug plan, so it's not even covering half of the cost of the drug. But we can provide sometimes copay assistance, going back to those patient support programs. Again, they'll go through their algorithm and see what they can provide. And we can see, well, if your insurance covers 45%, will the drug company cover the remaining copay amount for you? Maybe they'll cover most of it, maybe all of it. And you are able to get that drug through your Sun Life plan or your Manulife plan and pay nothing for it.
So I just wanted to make a comment about, I didn't want to be taken too literally about the brain and lymphoma comment. I think where this, I do think that companies, they vary, you know, they are very helpful if they appreciate that drugs are really expensive and provincial funding is either a while away or it's never going to happen. That's when the evidence is not that good and the costs are very high. I think as physicians, we think it's quite reasonable, for example, to use lenalidomide to treat follicular lymphoma. I don't think that's ever going to be a Health Canada approved indication. The company's not interested in, that makes it is not interested in filing it. The provinces may or may not ever take it up. We all think it's actually a reasonable thing to do. So I think most of the groups of lymphoma treaters that I'm aware of, it's true at Princess Margaret, we've sort of sat down and said, okay, there's a bunch of things that fall outside of what CCO and the new drug funding program provides and what drug benefits will provide. But you know, as a group, we think the evidence supporting this particular treatment is good enough that we want to try to make it available to people. So we have an infusion set up at our hospital. If you have insurance that pays for bendamustine for something that's not follicular lymphoma, it's possible to get that at our center, or there are some private infusion clinics around. So I think we know, you know, that there is evidence out there that would support the use of certain therapies. So as your advocates, we would say that we know that there's evidence to support drug X in lymphoma circumstance Y, even though the province isn't paying for it, and we kind of do what we can to make sure that you have access to that. And we also don't want you to mortgage your house or do anything like that to try to get to it. So there's definitely some blind spots, as it were, in terms of the things we want to do in terms of routine care that we try to do what we can to fill in. Sometimes actually the Ontario physicians go to the P-coder and we say, here's the data about this particular indication. We want to get a funding recommendation from you because the doctors want to do it. The company's not submitting it. We're submitting it to see that people can get access to it. So there's certain IV therapies that we think are really important that, as I said, that if the hospital is not going to pay for it, we try to figure out how to make sure that you can have access to it because we know the data are good enough to support it. without making it financially a huge burden.
One last question for you, Joe. Actually, sorry, Alan. Apologies. Could you expand a little about how you would work with a hematologist at a hospital to help with accessing medications? And how does your role fit in?
So we have drug navigators across Ontario. There's probably 60, 70 drug navigators in the province. If you're not from Ontario, there are drug navigators in the other provinces as well, except for Saskatchewan and Manitoba. But if you're in the eastern provinces, or if you're from BC, there are drug navigators in those provinces as well to do what I'm about to say. So what will happen is the physician will see their patient and go through the normal process of their consultation, explaining everything, and they'll come down to what treatment they want for that patient. And if it is not a routinely funded therapy, typically like an IV therapy through CCO, they will come to me and say, I need to get this. What do I do? So I typically am only involved if there's something more complicated than the routine stuff. So for example, if there's a new therapy available in the United States and they want to get this drug through the Special Access Program through Health Canada. So that's where we can access drugs that are not Health Canada approved. And they'll say, okay, what do I need to fill out? How can I get this for my patient? How long is it going to take? And then I start my investigation. So if they have a drug that's been prescribed that is Health Canada approved, I will see the patient. How old are you? Do you already have Trillium drug coverage? Do you have a private drug plan through work? Is there a patient support program with this new drug? All these questions have to be looked into as they're factors in getting this medication. If you have a drug plan, it can make things a little bit easier. If it's a brand new therapy and there's a patient program with it, then we can maybe be able to get it on a compassionate basis. Is the manufacturer quite large? Is it a big company that provides lots of financial opportunities for patients who are enrolled? Or is it a small company that only has this one drug and can't afford to provide more than just nursing support on the phone, something like that? So there's all these variables. The physicians kind of just turn to us and say, what's next? I have my next patient, right? And then we'll see the patient go through all of these steps to see if they're going to go through private insurance. We're going to make sure all the necessary paperwork is taken care of, making the right phone calls to the appropriate people to make sure that it's covered, and just kind of we navigate the system. And our goal is to try and get this medication as quickly as possible for that patient. And if we meet a roadblock, we can go back to the physician and say, well, this particular drug is not being provided by the manufacturer. We can't go through Health Canada to get it, but there's this other medication, or what are your top 3 choices, kind of, and then we just follow along from there and go through all the different pathways to see what's available.
So we've talked a couple of times today about clinical trials, why they're important. Dr. Kramp, I just wanted you to finish the panel off by telling us how does one get onto a clinical trial? What's the process like?
So this could be the referral. There would have to be there's a referral mechanism, of course, for same way you would get to see any other oncologist. But more of these referrals come to us, at least at Princess Margaret, from oncologists as opposed to family doctors. So the same thing. We'd have to have the pathology report and the imaging, in order to, and some other basic stuff about you, to understand whether or not you would be eligible. So you'd have to meet eligibility criteria. And as we talked about in our session, the reason for those criteria are about safety and understanding the results of the study. So do you have the lymphoma that's actually being studied in this particular study? Is there a match there? And then is it going to be safe for you to get it? So I think, so those are the 2 basic things. Some people wonder, why can't I be in this trial? And I had a conversation with one of my patients today, and her kidney function wasn't good enough. So there was criteria that say, like, if your kidney function is here, you might be taking extra risk, and we're still learning about whether or not there's benefit to this. So maybe you shouldn't do it. So the eligibility criteria are really key as far as the safety goes, and that can be frustrating because you just want to get better from your cancer and you can't fix your kidney function. But that can be a bit of an obstacle sometimes. So the information that comes to us hopefully has that information in it about organ function and that kind of stuff. Prior treatment history, how many lines of therapy has a person had. All of those sort of filter into the eligibility criteria. In a typical study, there's going to be about 17 or 18 of those and about another 20 reasons why people couldn't do it. So it sounds like a lot. But as long as you're well enough, and most people who are on clinical trials are up and about and getting dressed and sometimes going to work, but at least independent, then there's the potential that could work. So I think there'll be a screening process when you come to the hospital. You'll meet a clinical trials nurse who will kind of briefly review what the study's all about after we've talked to them, and then the nurses come in and actually give them the facts. That's what I've learned from working with nurses. That was a joke and only a couple people laughed. But they'll review sort of, this is what the trial's about, and here's a bunch of steps that you have to go through just to be considered to be in the trial. Like, you'll have to have some blood tests, and you'll probably have to have more up-to-date imaging, and maybe a heart test and some lung function tests, and maybe a bone marrow biopsy. So there's a bunch of screening things that have to be done in order to see whether or not you actually are going to meet all of those eligibility criteria. So you can, unfortunately, what can happen is you can come and do a lot of work and spend a lot of time, your time, and go through a lot of procedures and then still not be eligible, and that's regrettable. But it goes back to what I was saying, is that safety, in the face of unknown amounts of benefit, we want to minimize potential harm that way. Sometimes you might have to have another biopsy. A lot of research studies actually require a fresh biopsy that's part of the confirming the diagnosis, but also as maybe part of a diagnostic test that's being developed, or that's really germane to there's some molecular test or biological test that will make you eligible or not eligible for the study. So sometimes you actually have to have that biopsy before you can even participate in the study. And more of the studies we're doing are actually like that really require a new biopsy to be sure, 100% sure that the disease is correct and that the target or the biomarker is correct before we go forward. And so, of course, you're thinking, this must take a lot of time. I have to have another PET scan, another biopsy, and the answer is, yeah, it actually does. It takes quite a bit of time and a huge amount of work. And so when John this morning said not all centers do this, is because you need like a big team of people to make all of this happen in a reasonable length of time.
I can see Liz glaring at me, even though I'm not looking at her. Yeah. But I wanted...
It's because I talk too much, I'm sorry.
Joe, you had something really quickly too.
Just from the patient perspective, who initiates the interest in clinical trials? Can the patient say, are there any trials that I can participate in, or does the doctor initiate that?
So I think it's a good conversation to have with your doctor, because it's not always clear. Like, I don't know what studies are being done at Sunnybrook. I probably should, or at St. Michael's, or at Roswell Park in Buffalo. So nobody really carries that around in their head, but at the same time, we know that at a certain point, something other than the same old stuff we're doing is important. So yes, you can definitely, with your oncologist, or sometimes it actually happens through family physicians as well, to say, is there a trial out there? Many times these conversations happen by email or by phone with your physician about whether or not, in broad strokes, whether we have a study for this particular condition or not. So you may get an answer pretty quickly. Sometimes that answer might be no, but sometimes you'd have to make the journey with your CD and your bundle of reports and CS. But you can definitely initiate that. The most efficient way, I would say, to initiate that is through conversation with your oncologist. And like I said, if I knew there was a study that my patient was going to be eligible for at Sunnybrook, and we weren't doing a study, I would send them to Sunnybrook.
Fair. And that's great. So communication is key. Thank you for a very informative session, Dr. Crump, Joe, Alan, Shannon. Thank you so much.